Welcome to Last Minute Lecture. This free chapter overview is designed to help students review and understand key concepts. These summaries supplement, not replace, the original textbook and may not be redistributed or resold. For complete coverage, always consult the official text. So if we look back at the early 2000s, prescriptions for hormone therapy just completely plummeted, like by roughly 80%, practically overnight.
Yeah, it was a massive drop.
Right. I mean, we thought we were giving patients this shield against aging, but suddenly the data suggested we were actually handing them a fast track to heart attacks and strokes. And breast cancer, too.
It really was one of the most dramatic pivots in modern pharmacology.
It was. But then years later, as we looked closer at the mechanisms, we realized that initial data was, well, he was kind of telling the wrong story.
Exactly. And the fallout from that era is still felt in clinics today, you know. It created this huge hesitancy around prescribing hormones, even when they are absolutely the most effective, rational choice.
Right, which means we need to fix that narrative.
We do. To understand how we got it wrong back then and how we get it right now, we basically have to completely rethink our approach to manufactured hormones.
And that brings us to you, the advanced practice nursing or physician assistant student listening right now. Welcome to this custom deep dive. Think of this as a highly targeted one-on-one clinical reasoning session from the Last Minute Lecture team.
We are so glad you're here.
Absolutely.
Yeah.
Today, we are unpacking Chapter 50 of Lane's Pharmacotherapeutics. We're focusing intensely on the basic pharmacology and the non-contraceptive applications of estrogens and progestins.
Which is such a crucial topic because we're dealing with a biological system that is less like a simple machine and more like a highly sensitive, interconnected, smart home thermostat.
Oh, I love that analogy.
That thermostat idea is critical because in the hypothalamic pituitary ovarian axis, every single adjustment you make alters the feedback loop.
Right.
You can't just introduce a manufactured hormone without knowing exactly which receptors it's going to bind to or, you know, how it will alter gene transcription and what secondary cascades it's going to trigger in the liver, the bones, and the brain.
So let's jump straight into that cellular level. I know you listening already understand the basic 28-day menstrual cycle. You know, the follicular phase pushing FSH, the LH surge triggering ovulation, the luteal phase.
Yeah, the baseline physiology.
Exactly. But let's look at the tissue level goal of these endogenous hormones. I still use the classic analogy. Estrogen is the contractor building a house, and progesterone is the maintenance crew keeping it stable.
It's honestly a great framework to use. During the first half of the cycle, estrogen, primarily estradiol produced by the ovaries, is that contractor.
Right, doing the heavy lifting.
Exactly. It drives the intense proliferation of the uterine endometrium. And then progesterone, the maintenance crew secreted by the corpus luteum, steps in.
To keep the house standing.
Yeah, to maintain that endometrium in a highly vascular, hypertrophied state, getting it ready for a fertilized ovum. And if implantation fails, the maintenance crew leaves, the lining slows off, and the cycle just resets.
But the pharmacology gets complicated, right? Because estrogen doesn't just stay in the uterus. As a steroidal hormone, its mechanism of action is, well, it's fascinating. It doesn't just knock on the cell surface. It has VIP access.
It really does. Estrogens are highly lipophilic, so they diffuse effortlessly right through the cell membrane. They migrate straight into the nucleus, and they bind to specific estrogen receptors, primarily ER alpha and ER beta.
Right, directly to the DNA.
Exactly. Once that hormone receptor complex forms, it binds to estrogen response elements on the DNA itself. It fundamentally alters the rate of gene transcription.
Wow.
That is why its effects are so profound. I mean, it is literally reprogramming cellular behavior.
Yeah, but if it's altering gene transcription, that process usually takes hours or even days to manifest, right? So how do we explain the immediate physiological responses we sometimes see, like rapid vasodilation?
Oh, that's the dual nature of estrogen. While its primary mechanism is nuclear transcription, it also uses these distinct surface receptors. Yeah, binding to those membrane-bound receptors triggers rapid intracellular signaling cascades. It's like hitting the panic button, so to speak, for an immediate physiological response without, waiting around for new proteins to be synthesized.
That makes so much sense. So when this powerful dual-action hormone circulates systemically, it acts as a massive full-body shield. Outside the reproductive tract, it's doing incredible things. Take the skeletal system. Estrogen blocks bone resorption. But how exactly?
Well, it promotes the apoptosis, the programmed cell death of osteoclasts. Those are the cells responsible for breaking down bone tissue.
Right.
By keeping osteoclast activity in check, estrogen ensures that osteoblasts can just maintain the bone mass.
And in the cardiovascular system, it's highly protective too. It activates receptors in the vessel endothelium to produce nitric oxide, forcing vasodilation. Plus, it alters the lipid profile in the liver, lowering LDL and raising HDL.
Very protective.
But here's the paradox that I always stumble on. Estrogen promotes blood coagulation, but it also suppresses it. How can a drug do both simultaneously?
Yeah, it's confusing at first. It all comes down to liver protein synthesis. Estrogen increases the plasma levels of certain coagulation factors like factors 2, 7, 9, and 10, which promotes clotting.
Okay, so that's the pro-clotting side.
Right. But concurrently, it increases the levels of plasminogen and antithrombin. And those are factors that actively break down fibrin and suppress coagulation.
Oh, wow.
So the net effect, whether a patient is more prone to a clot or not, often hinges on their hereditary genetics, like the presence of underlying mutations such as factor V Leiden.
That genetic variable is such a huge clinical pearl to remember. Estrogen also provides neuroprotection against oxidative stress and helps maintain glucose homeostasis, right, by increasing insulin sensitivity.
It does, yes.
So if we look at this full-body shield, the pathophysiology of menopause really becomes a story of systemic withdrawal. When ovarian estrogen production declines, which is typically around age 51 or 52, what actually happens to the patient?
Well, the withdrawal triggers widespread alterations. The most immediate are the vasomotor symptoms.
The hot flashes.
Exactly. Without estrogen regulating the thermoregulatory center in the hypothalamus, patients experience intense hot flashes and night sweats. You also see genitourinary syndrome.
Right, because of the receptor density.
Yeah, the urethra and vagina have incredibly high concentrations of estrogen receptors. So when estrogen disappears, that tissue literally atrophies. It leads to severe vaginal dryness, dyspareunia, and urinary frequency.
Not to mention female sexual interest arousal disorder, anxiety, and cognitive changes. And physically, without estrogen forcing those osteoclasts into apoptosis like we talked about, bone loss accelerates rapidly into osteoporosis.
The lipid profile also flips with LDL climbing,
Which naturally establishes our therapeutic goals for menopausal hormone therapy, or HT. The obvious goal is replacing the lost estrogen to manage these severe alterations. But we also use manufactured estrogens for other things, right?
Yeah, for female hypogonadism to induce puberty, for severe acne in select populations, and paradoxically for cancer palliation in advanced prostate cancer or metastatic breast cancers.
Bringing in manufactured estrogen, however, introduces side effects. Nausea is notoriously the most common, though the text emphasizes that taking it with food or at night really helps, and it diminishes over time.
True, but there are much heavier risks to watch for. Gallbladder disease, jaundice, severe migraines, fluid retention, and cloasma, which is that patchy facial discoloration.
And the mechanisms behind those risks dictate our absolute contraindications, right?
Absolutely. Because of how estrogen alters liver protein synthesis and coagulation cascades, it is completely contraindicated in patients with any history of deep vein thrombosis, pulmonary embolism, stroke, or myocardial infarction.
That's a hard rule.
A hard rule. You also never prescribe it for patients with undiagnosed abnormal vaginal bleeding, pregnant patients, or those with estrogen-dependent tumors.
We also have to master the pharmacokinetics here, specifically the cytochrome P450 system. Estrogens are major substrates of the CYP1A2 and COP3A4 enzymes in the liver. Let's say you have a patient who is well managed on hormone therapy, but then they're prescribed a new medication that happens to be a CYP3A4 inducer. What happens?
Well, the liver enzymes basically ramp up production and start chewing through the estrogen much faster than intended.
Huh.
Yeah. The patient's systemic estrogen levels will just plummet, and suddenly they're experiencing breakthrough hot flashes and night sweats all over again.
And conversely, a CYP inhibitor would cause estrogen levels to build up to toxic levels, right?
Exactly. Increasing side effects like nausea and fluid retention. They can also heavily interact with anticoagulants and antidiabetics, so they require really close monitoring.
This heavy reliance on liver metabolism directly informs rational drug selection, particularly regarding administration routes. The chapter details transdermal versus oral administration. Why would a clinician specifically choose a transdermal patch like Climora or Viveldot or a gel like Divigel over a standard oral pill? I mean, is there really a difference if it's the exact same hormone?
There is a profound difference, actually, and it is entirely due to the first pass effect.
Okay, break that down first.
When a patient takes an oral estrogen pill, it's absorbed through the GI tract and delivered straight to the liver via the portal vein in massive concentrations. This intense, localized concentration strongly stimulates the liver to synthesize those clotting factors we discussed earlier.
So that is what drives the DVT risk.
Precisely. Transdermal routes bypass that first pass effect. The hormone enters the systemic circulation directly, just dripping slowly into the bloodstream.
Oh, that makes sense.
Because it's not bombing the liver all at once, the total required dose is much lower, blood levels fluctuate way less, nausea is reduced, and crucially, the risk for BVT, pulmonary embolism, and stroke is significantly lower.
Patient education for transdermals is incredibly specific, too. The text explicitly states patches go on the trunk or abdomen, never on the breasts or waistline. Gels go on the arm or thigh. Now, what about the intravaginal routes, like creams or rings?
Intravaginal applications are generally designed strictly for local effects, basically treating that genitourinary atrophy without causing systemic changes. But clinicians must memorize one major critical exception, and that's the femring.
Right, the femring releases enough estrogen to actually enter systemic circulation. It treats the hot flashes, but it also carries the full systemic risks of thrombosis. It's completely different from the estring, which is local only.
Exactly. Now, patients often try to avoid these risks entirely by asking about phytoestrogens, plant-based isoflavones like soy or red clover.
Right. And what is the clinical reality there? Because we all know natural doesn't automatically mean safe, right?
The clinical reality is that the evidence for phytoestrogens from randomized controlled trials is wildly inconsistent, so they aren't formally recommended.
Interesting.
But the absolute critical safety point here is that phytoestrogens interact with estrogen receptors. Therefore, they carry the exact same theoretical risks as manufactured estrogen.
Wow, okay.
A patient with a history of thromboembolic events or estrogen-dependent cancer should absolutely not use large amounts of soy extracts thinking they are somehow bypassing the danger.
That is a dangerous misconception to clear up, for sure. Now, pharmacology's answer to this whole paradox, the desire for the shield without the cancer risk, is the development of SERMs, or selective estrogen receptor modulators.
Yes, SERMs are fascinating.
I like to think of SERMs as smart switches. They walk into the body, and because of how they interact with cellular co-regulators, they turn the estrogen pathway on in some tissues and turn it off in others.
It is an elegant pharmacological solution, but none of them are perfect. Let's break down the four main SERMs you'll see. Tamoxifen was the pioneer.
Right.
It acts as an antagonist, blocking estrogen receptors in the breast, making it a cornerstone for treating and preventing breast cancer. Simultaneously, it acts as an agonist in the bone, protecting against osteoporosis.
Wait, if it acts as an agonist, it's mimicking estrogen. Doesn't that mean we are giving a breast cancer patient a drug that could cause cancer somewhere else? Are we just trading one risk for another?
Unfortunately, yes. Because tamoxifen acts as an agonist in the uterus, it forces endometrial proliferation. So that poses a very real risk for endometrial cancer. It also triggers hot flashes and carries the DVT risk.
That sounds like a really tough clinical choice.
It requires a very careful risk-benefit analysis by the clinician. To solve the uterine cancer problem, we developed raloxifene.
Okay, raloxifene protects the bone and the breast, but unlike tamoxifen, it does not act as an agonist in the uterus. So no uterine cancer risk there, though the text notes it still causes hot flashes and carries a risk for venous thromboembolism.
Exactly. Then you have ospemifene, which is highly specific. It acts as an agonist purely in the vaginal tissue to treat severe dyspareunia. It does nothing for hot flashes.
And finally, basidoxifene, which is utilized in a combination drug called Duavi, right?
Yes. Duavi combines conjugated estrogens with the SERM basidoxifene.
And the estrogen handles the vasomotor symptoms on the bones, while the SERM acts as an antagonist specifically in the uterus to prevent excessive lining growth. It's an ingenious way to protect the uterus without using a progestin.
It really is, which is the perfect bridge to our second major hormone class, the progestins. The maintenance crew, as you called them. Endogenous progesterone, which is secreted by the corpus luteum and later the placenta, transitions the endometrium into a highly secretory state.
And if a pregnancy occurs, progesterone levels become massive. What's the mechanism there?
It acts as the ultimate biological stabilizer. High levels of progesterone profoundly suppress the contraction of uterine smooth muscle.
To protect the pregnancy.
Right. This stops the body from rejecting the implanted embryo. However, because it is circulating systemically, it also suppresses gastrointestinal smooth muscle. This decreased motility is why prolonged transit time and constipation are such, universal complaints during pregnancy.
Makes total sense. So how do we harness this stabilizing effect as a therapeutic tool when a patient isn't pregnant?
In non-contraceptive applications, we primarily use progestins to counteract estrogen. In menopausal hormone therapy, if you give systemic estrogen to a patient who still has a uterus, you absolutely must administer progestin to stabilize that lining.
Otherwise, the estrogen just keeps building it up.
Exactly, and you have to stop the estrogen from proliferating it into endometrial cancer.
We also use it to treat dysfunctional uterine bleeding, right? The pathophysiology there is often a lack of sufficient endogenous progesterone. Estrogen just keeps building and building the lining until it gets too thick. It grows its blood supply and randomly slews off, causing irregular, heavy bleeding.
Right. By administering a progestin for 10 to 14 days and then suddenly stopping it, the clinician can stabilize that chaotic endometrium and then induce a controlled, predictable withdrawal bleed.
We also use progestins to support early IVF pregnancies. And there's a specific formulation, McKenna, approved to prevent preterm birth in certain high-risk patients.
But safety parameters dictate we have to monitor for adverse effects. Things like severe breast tenderness, irregular breakthrough spotting, and notably an increased risk of breast cancer when progestins are used in combination with estrogen postmenopause.
Wow, okay, so all of this pathophysiology and pharmacology culminates in the most critical part of Chapter 50, the clinical guidelines for menopausal hormone therapy.
Yes, the core of the chapter.
And to understand the modern guidelines, we have to revisit that early 2000s panic I mentioned at the beginning. You know, the WHI Women's Health Initiative and the HERS studies. They linked hormone therapy to heart attacks, strokes, and breast cancer. But the clinical reasoning flaw wasn't in the raw data itself, was it? It was in how the researchers applied it.
Exactly. When modern pharmacologists scrutinized the WHI methodology, they realized the subjects in those early studies were mostly older women. I mean, the mean age was 63.
Oh, wow.
Yeah, many were a decade past menopause. Their vascular endothelium had already been without estrogen for years. Plaque had already formed. So when you suddenly introduce systemic oral estrogen to a 65-year-old, you don't get protective vasodilation, you get plaque destabilization and thrombosis.
But when researchers isolated the data for patients aged 50 to 59, which is the actual demographic who starts HT for hot flashes, and limited the therapy to less than 10 years, the risks plummeted.
Crasting.
In fact, for people aged 50 to 59 on short-term therapy, overall mortality actually decreased by roughly 5 deaths per 1,000 women compared to those not taking HT. That's incredible.
It is. This realization completely reshaped the clinical algorithm. The chapter outlines strict rules for rational prescribing today. Rule number 1. HT is only approved for 3 specific indications: moderate to severe vasomotor symptoms, moderate to severe genitourinary syndrome, and the prevention of postmenopausal osteoporosis.
Got it. Rule number 2. Use the lowest possible dose for the shortest possible time. And route matters. If your patient only has genitourinary symptoms like vaginal dryness, you do not expose their liver and vascular system to an oral pill.
Right. You prescribe a local vaginal estrogen, like a cream or the estring insert.
We must also firmly establish the inappropriate uses. You never prescribe HT for the express purpose of preventing cardiovascular disease. And you never prescribe it to prevent dementia.
No. The WHI data clearly demonstrated that HT actually increases the risk of dementia in patients over 65.
So what if you have a 52-year-old patient suffering from debilitating hot flashes, but they have a history of DVT, so estrogen is completely off the table? The algorithm provides non-hormonal alternatives, doesn't it?
It does. SSRIs and SNRIs, specifically escitalopram, desvenlafaxine, and paroxetine, have shown meaningful reductions in vasomotor symptoms. Gabapentin and clonidine are also utilized off-label.
Good to know. And now we arrive at the golden safety rule of this chapter, the black box warnings. Every clinician prescribing these medications must have this committed to memory.
Let's spell it out clearly.
Unopposed estrogen in a patient with an intact uterus significantly increases the risk of endometrial cancer.
Therefore, if a patient has a uterus, they must receive EPT estrogen plus progestin. The progestin is entirely there to protect the uterus.
Right.
Conversely, if a patient has had a hysterectomy and no longer has a uterus, they receive ET estrogen alone. You do not give a progestin to a patient without a uterus because the progestin is what drives the increased breast cancer risk in combined therapy.
Right. Both ET and EPT carry black box warnings regarding the risks of DVT, stroke, and dementia in patients over 65.
Exactly.
So once a patient is ready to discontinue HT, how do we safely taper them off so the vasomotor symptoms don't roar back with a vengeance?
The guidelines offer 2 tapering methods: dose tapering and day tapering. Dose tapering involves taking the medication every day but slowly shrinking the milligram amount. Day tapering involves keeping the dose amount identical, but increasing the interval between doses, taking it every other day, then every third day.
Okay, simple enough.
But the critical safety parameter here is that you only taper the estrogen.
Because if they still have a uterus, the progestin dose must remain fully unchanged to ensure the endometrial lining remains protected against that dwindling estrogen, right?
Exactly. Finally, we must review the lifespan tables. Estrogens and progestins are heavily contraindicated in pregnancy. During breastfeeding, they can cause neonatal jaundice and significantly reduce milk production.
And for older adults.
They are explicitly listed on the Beers criteria as potentially inappropriate, primarily due to those cardiovascular and cognitive risks we just mapped out.
So synthesizing everything from the CYP enzyme interactions down to the black box warnings, the core takeaway for safe prescribing is balance.
Very much so.
We're balancing the undeniable quality of life restoring benefits of short-term hormone therapy against the age-dependent risks of systemic exposure.
It requires meticulous clinical judgment. You have to evaluate the patient's age, their time since menopause, their individual cardiovascular risk, their genetic coagulation profile, and whether or not they possess an intact uterus. Only then can you make a rational drug selection.
Which leaves you, the future clinician, with a final thought to mull over. We saw how the WHI data shifted dramatically when we simply looked at the 50 to 59 age group, revealing an actual decrease in overall mortality. As pharmacology continues to engineer more precise smart switches like SERMs, and as our understanding of bypassing the liver with bioidentical transdermal dosing improves, how might future clinical guidelines continue to shift? Could we eventually see customized, genetically tailored hormone profiles designed not just to alleviate hot flashes, but to actively fine-tune human longevity at the cellular level?
It is a fascinating question to keep in mind as you encounter new research and updated guidelines in your practice.
It really is. We want to thank you for diving deep with us into the advanced pathophysiology and clinical decision-making of Chapter 50. A huge thank you from the Last Minute Lecture team. We wish you the absolute best of luck on your upcoming exams and your clinical rotations. You have got this.